start off by asking a question, and we're going to start flip charting this. What are your takeaways from today? What did you hear today? Concerning, positive, what? Pam?
I think as patient advocates, we need to prepare our patients to have those individual questions with their doctor. I mean, a lot of the last discussion was around whether or not you knew whether your physician was using a guideline or a pathway, but we didn't really talk about some of the broader issues that patients care about, which is how much is this going to cost me, what are the potential side effects of these drugs. I mean, there are a lot of questions that patients have to ask an oncologist in an average 12-minute visit. So how does that really work? And I think a lot of that, what we work at on at the American Cancer Society is getting people to kind of journal their experience, bringing paper and pen into their meetings. But I think one of the key tools that we will be bringing to patients is questions to ask their doctors. So they kind of know, I mean, these are difficult questions to ask, but having our own checklist, much like the airplane, I think would be helpful.
Great. What else? What else did you hear today in the messages?
Yeah. I think to Kim's point, there's a lot of education that we can do to educate our own patient communities. I'm sure most of the people that I support have no idea what is a pathway, what's a guideline. We have NCCN guidelines in a rare disease, but it's really art. There's not science, and there's not enough of a patient population to provide evidence yet. So how do we begin to pull together education of the population of people that are actually on the receiving end, and then to begin to capture their experience so that we can culminate that in a way that brings real data. What's the real impact of this to the people that are making policy or payer decisions? Because it seems to me that it's being done in a vacuum as usual, which, everybody calls it patient-centric, but how many people in the room are patients at some point in time in their life, or their loved one is a patient? So, we're all going to be part of this. So how do we bring it down to that level and then use the data?
Yeah.
So I think one of the concerns I've always had is we're measuring people. A lot of the pathways that we've been talking about, quality measures and so forth, are looking at whether you did a certain percent of the time, whether you gave that drug in the right way, in the right circumstances. But what we're not measuring is, for that patient, did they get everything they needed? I mean, you as a doctor being measured on, I gave, the right chemotherapy for, stage 2 breast cancer 99% of the time. That says nothing about whether each of my patients got all the things that they needed at the right time in the right place. So I think, it's challenging. There's been a lot of concern about what are the outcome measures. There's life and death, but what are the other outcome measures in oncology should we be thinking about? And I'm not sure we have it right.
I just also heard I know Heidi had to leave, but you heard this call for additional input and feedback on the process as things are coming together, maybe less so in the pathways discussion, but I think this idea of, what CMMI has put together and this idea of episode or bundle payments, those are still very much open. And I hear ASCO saying the same things, and so I think that that's something else to keep in mind as we work with our constituencies, to be sure that we're pulling, like you were saying, pulling from our own patient experiences to help inform those processes before they're fully cooked.
Good. Anybody else?
I think building on what Pam was saying, the concept that patients are being diagnosed with cancer and thinking, I wonder what pathway I'm going to be on, is so ridiculous. And so, health literacy in this country, there's only 12% of 300 million people who are proficient health literate. And so I think if we're talking about patient-centered care, we're so far up here in the clouds that it's not even in the realm of what people are thinking about or worried about. And I feel like they trust us as patient advocates to help them we're here to do that work and to figure it out and to play nice in the sandbox and be adults. They're there to live. And I feel like if we expect patients to understand pathways and put the onus on them to ask questions, that's just ridiculous.
So you need to make it easy for them.
It's so easy.
Yeah, right. And props to Dr. Carlson for his comment about patients being able to handle information.
Yeah,
that's a big switch over the last couple of years. So really, really thank you Thank you for that. We agree wholeheartedly. Oh, yeah, sorry, Libby.
So I'm going to take off my CSC consultant hat and just give you a perspective that I think could be really valuable. Someone who sat on the Hill for 8 years and heard from cancer groups all the time, very body part specific cancer groups about policies they would like, or from a CMS regulator standpoint. I think when we talk about the patient voice, it is so incumbent upon the community to really work collaboratively and identify both the semantics and the policy ask first, so that you can leverage your impact. I think this is just one of these issues that's going to fall on deaf ears if there's 15 groups tramping through CMS and meeting with Heidi or on the Hill. As much as this is about patients and them understanding the literacy, from a policy perspective, I think it's incredibly important that this community get on the same page first.
I think, Linda, to Louis' point, I think it's the same issue when it comes to the patient education piece and when it comes to the policy piece. I mean, this conversation is reminiscent of some of us who were together at ASCO in 2013. We were in a meeting, Jeff, I think you were there, we were in a meeting and conversation about how patients didn't even know what questions to ask when it came to shopping on the state exchanges. And there were 20 of us who came together, 20 organizations who came together to create a cancer insurance checklist that really gave cancer patients a list of the key questions they needed to ask about what was going to be included on the exchange before they pulled the trigger and bought that plan. I don't know, I just am seeing maybe here an opportunity if there are other groups. I mean, I think at CSC we're really going to go ahead with some patient education about clinical pathways and create some simple, Elizabeth, like you said, you got to start with the basics, and I know your social work background certainly informs that quite a bit. But I think we're going to go ahead with the creation of some basic educational materials for patients about pathways. Not only the information, but I think to your point, Elizabeth, and we've been talking a lot about this idea it's about skills building. It's a little bit of role playing, it's a little bit of skills building, and giving them not only the information, but the tools to navigate some of this. So I think we're going to go ahead. We've been talking about this internally with some key materials, trying to get those definitions down, Libby, like you're describing, from both an educational standpoint, and then what's the policy piece on this. So I don't know, I would just invite folks, if your organization is interested and you want to start maybe convening a little bit of a work group on this, so we can be creating, again, that whole idea, not really reinventing the wheel on oncology, we can be creating, a unified policy ask and also some unified educational materials. I mean, I would just ask maybe specifically, what I will ask people to do is to see Kim Ryan at the end of this, and if your organization would like to go next step to create this working group and come together on some of these materials, let's go ahead and do that. And I'm hoping maybe there are a couple of funders in the room who might be interested in supporting that work, particularly if we do come together as a little bit of a coalition around these efforts. So I would just offer that, Linda.
Great. Kim went right to the next steps.
Oh, sorry.
So with that, the interim or the interim step is anyone already doing something, right? What are you doing to help patients understand medical home pathways? What's going on? I know that we're doing a radio show. So Jen Malin, who was invited to be here today, by the way, as was Lee Newcomer, has agreed to come on, frankly speaking, about radio with myself or Kim. To talk about pathways and how do we educate consumers. So what else is going on from your organizations in the room, or what else do you know of? Yes, Ted.
So, Linda, we have been working with the Commission on Cancer for an accreditation program around the oncology medical home. And unlike what Bob mentioned in terms of the hospital, there is an accreditation for hospitals. This is built from the ground up. And it's built around 5 domains. It goes back to, started with all the research that we've done with patients. I mean, so literally patients and even patients being involved with this, it's along 5 domains. And I won't bother everybody. If you want to see, we're actually almost finished with the manual for practices. And in fact, the 7 come home practices and 3 other practices are going to be piloting and going for accreditation in the first quarter of 2005. So along those domains, and one of the domains is access. So it goes to this, 24/7 and triage and all of that. We are actually looking at and have identified all the educational needs for both the patients as well as the providers, because there's a lot of need on the provider side as well too, but it starts with the patients. And we are looking to actually develop a whole series of educational elements around this that have to deal with not just you walk in the door, Kim, is what's the, what's an oncology medical home? What does that mean for me? But on literally every facet of it, and not just the big ones like, okay, you're a survivor now, what's a survivorship care, what's a treatment plan? A lot of elements of that, because we have all identified a big need in that area. And what was actually really curious at this summit that we held at, whatever it was, 3-4 weeks ago in DC, this payer summit, it was the payers who actually talked about the need for some education here within, the practices that are implementing some of these pilots. And no offense on the payer side, but you wouldn't think they would be the first ones to say it. So, I mean, I can just tell you from our perspective with this whole oncology medical home initiative that we have, and with that, education is a huge one. And we actually have a worksheet, a spreadsheet that has identified along these domains, these 5 big domains, very patient-centric, what are all in the subdomain and elements, what are literally the needs. And we're looking at a series of print as well as sort of video-based education around that.
Okay. So do we have the opportunity to partner with you on that?
You absolutely, as I was sitting here and I was talking, I was saying, absolutely, we need to partner with that, because frankly, and I'm not just giving lip service, but if we don't do that with a patient voice involved, if it just sort of comes from the provider side, well, you get what you...
It's a provider's voice.
Yeah, right, exactly.
Yeah. Okay. Anything else? Yeah, Tamara?
Ted, can I ask what those domains are? It's access and, do we know the other, I can't think of.
Yeah, it's evidence-based. There's a number of, I can actually send you the domains and the subdomains. It's all available. It's available on our Oncology Medical Home website. But I can actually send you those and then some of the domains. But it has to do with evidence-based care. That's where the pathways are under that. So I can send you that.
That's fantastic that you have created that, and thank you.
Yeah, and when we have I'm really impressed. I have not been involved in the details of this manual, but when I looked at where the manual was, which is literally about 90% there, you think of a manual as being, oh, gosh, what is that good? It was really insightful because it breaks down the care process like I've never seen it broken down before. And the nice thing about where we're going on the CLC is it's not just a checklist. I mean, you have to do it, and there is a site visit where someone comes out and has to look at it, the proof. So it's not just the provider just saying, check, 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 here we're doing this. So it's not going to be all that easy. I mean, it's going to be, you do the right thing, it's going to be easy, but it's not going to be all that easy.
Great. So we've got Ted down first on your list of groups that want to collaborate with us. Move forward. Great. Anything else? Anything else that you're aware of? Anything that we need to think about as we think about what a collaboration could look like? Let's move to next steps. Any thoughts about how we should tackle this? Come on, guys. I know you guys are going to have our ear when we walk out of here. You're just afraid of the video camera.
Well, how do they know?
I know. Okay.
So one thing comes to mind. I mean, I'm thinking back many years ago to when then HCFA released mortality data about hospitals, right? And they had the expectation that patients were going to take that information and make choices. And almost none of it happened. So, maybe it's our previous discussion and a little bit of this discussion, which is beyond the list of questions, for example, that a patient might ask their doctor, what do they do with that information once they have it? So okay, doctor, are you giving, are the choices you're giving me because you're being paid some kind of incentive to use those drugs? Yes. Okay. What, now what? I'm being insured by Aetna, and Aetna requires that, and I have no other choices. So, I mean, maybe there's a component of advocacy, and is there a policy piece of this where every patient should be able to expect, no matter what the choices are, they're appropriate? And then within that, there's some flexibility, but I don't know. I mean, I don't have the right answer to this, but I think just dumping information on people without some way to deal with
Advocacy,
it.
some outlet for them to do something.
Right.
about it.
Right, and I think that was also the ability for patients, if they understand it, the ability to go the next step.
Yes.
To say, what's not, okay, so what didn't you lay out?
Right, exactly.
That's on the table. What are some of the other choices? And what do you as
Yeah.
my doctor think about what's on versus
Exactly.
what's off? And based on what you know about the results of my biomarker tests, and based on what you know about my other comorbidities, and based on everything else that you know about me, doctor, as a patient. So let's look on, let's look off,
Yeah.
let's look at side effects, let's look at what I can afford.
Right.
And then let's make that choice. And so I think it's just a matter of giving patients that little bit of information so that they can have some comfort in going the next step with that line of questioning and with the conversation.
And with the tools to go to that.
And with the
next step.
tools
Yeah.
to go to that. And it's just, I think I really want to emphasize that it's not just about a brochure. I really do think it's about skills building, it's about role playing, it's about, and I also think that what patients want or need or are going to be able to utilize, I think there also might be, you talked, Elizabeth, about a literacy breakdown. I think there also might be a generational breakdown in terms of who's willing to challenge and raise these questions. And so I think we have to take all of those pieces, into account. But I think we have to start, somewhere and get moving.
Right. Well, in the appeals process, right?
Well,
so
so
like,
if it doesn't work, what do you do?
how do I
next?
appeal it?
Right, or even before that, it's so if you say, this is what I can get if it's on pathway and this is what I can't get, well, what if the patient says, well, what happens if I want the thing that's not on pathway?
Yeah.
Right, and will you help me with that, doctor? Or am I on my own? If you won't help me, where can I go? And is there someone who can help me?
Yeah, so all pieces that need to be. One of the things I would say that we absolutely have to do is do a little bit of a survey, right, with patients, more so than we have either in the registry or here, but a more targeted survey to say, where are we starting? Where are we starting from, right? What do you want to know? What is important to you? Those sort of things. And we would certainly do that. Yeah, fine.
I think related to that, it would be important to connect this conversation and the advocacy piece of it to the beginning of the conversation we had today on network advocacy. Because then if you are stuck and you say, well, my doctor's just not willing to work with me or answer my questions, but you don't have any other doctor cases. So I think we need to figure these things together instead of separately.
Yeah.
And I would say that the whole discussion this morning too about patient preferences and life goals and where your aspiration is, how do these restricted pathways limit some of your options as far as making sure your life goals can be met?
Like the neuropathy. Yeah, I use that as an example. So we have an open options program where it's a treatment decision counseling model, and one of our patients said, I have been diagnosed with a terminal illness. I'm a concert pianist. All I care about is playing the piano till the day I die. And was able to go back and share that information with their physician, and the treatment plan changed for this particular woman. So I think about when I read those pathways through, what options this woman would have had, if somebody hadn't gone to that level of conversation with her. Okay, what else? Did you have a comment, Lauren? Did I?
Nope, fine.
You're good?
Got it.
Okay, great. Anything else, Mark?
When you get the piece done, you might want to test it with physicians and patients, but sort of behind the door, and have like Verilog do some of the testing with that. They tape record, obviously, probably send to the physician and the patient the conversation, and do a bunch of those and see how it comes out. You can use that as potential training for both patients and physicians on how to actually have the right conversation.
Yeah.
Here's a good conversation, and here's not such a good conversation.
Good. Anything else?
I think, this is pretty obvious, but I think from the patient advocacy guys, the advocacy side, you guys need to really push both the insurers on the payer side as well as providers to create that transparency about what's happening with their care, especially as it may go towards a pathway and some of the ramifications around that. Of course, then the $64,000 question is, you have to provide, okay, not just some little brochure, but a little skill set. Okay, what does that mean in terms of what questions should you be asking? What are the ramifications? And by the way, I think it was asked of Lauren, may have asked Mark today, but when I say patient, in my mind, I'm talking patient, caregiver, and even survivor, but especially that patient caregiver. In terms of that, I think that's really important, because I can't tell you how many times, I sit at home at night, and of course, without specifics, my wife is talking about the caregiver really making the decision, the caregiver really being there, asking a lot of the tough questions, because that's the way it is a lot of times.
Right, absolutely.
We can reach out to caregiver appreciation.
Yeah, well, we're launching a caregiver registry right at the turn of the year, so we'll start to collect some of that data around what's important to them.
Linda?
Yeah.
So just one other variable, I guess, to consider, that conversation might be, and you want to know if you're going to be subject to a pathway, what's been the results with these pathways? I mean, so you're not going in blind, you're not the guinea pig, so to speak. I mean,
As part of the question set for the patient.
yeah, I mean,
To
what
ask for outcomes.
yeah, exactly, what have been the outcomes, both on the total cost and the quality of care, all those different things.
Yeah, unfortunately, they don't exist, but we
Well,
should challenge people to make them exist,
that's
right?
exactly
Yeah.
right.
And particularly the patient satisfaction outcome that I keep talking about when we're looking at some of the decisions we're making. Jeff, somebody had a question over here. Jeff, was it you?
Yeah, it would be possible to, Kim mentioned earlier that it was very difficult to really create transparency and understand what went into some of the decisions and how these pathways were originally developed as much as you asked for it. I don't think there's a lot of leverage there. If the answer's no, then the answer's no. What are you really going to do? I think it would be a big expectation to think that there will be a groundswell of people that are going to move to the exchanges and try and find a different health plan because they don't understand what went into the pathways of the coverage that they have. But in order to try and create a little bit of leverage and a level playing field of information, would it be possible to create some sort of survey to the pathway developers that could have a common set of questions to better understand things like, were patients involved in developing your clinical pathway structure? If so, how? Or did you take patient preference information or patient-reported outcomes into account for your pathway construct? If so, how? To try and create that transparency rather than just demand it.
I also wonder if there's a list of common questions, outcomes-related questions, to say, if you have a certified pathway or an accredited pathway, you must be able to provide data on X, Y, Z, right? Overall survival or whatever that is. Kara, do you have something?
Yeah, I was just thinking we might be able to look at some other disease settings that have maybe kind of restrictive formularies that are in place, and maybe learn from some of the patient advocates in those disease areas, what's working, what are some of the things that they're doing to help patients through some of those challenges.
Do you have any disease areas that you would suggest are more advanced than others?
I'd have to take it back and think about it a little bit. I've been in oncology for too long.
Okay.
And
I'm just biased, so I'll just admit that right now. Kim?
Linda, I also think that maybe part of our joint effort, I think to the point about what are the payers doing, and to the point about the outcomes question is, I know from our standpoint in the near term, we want to educate patients about what the reality is right now, right? There are pathways in place, patients may be treated on them, there are certain aspects of it that we can take on right now. But I think there are broader and longer term questions about, what are the implications of these? When are we going to get some quality or outcomes data around these pathways? I think that, when you look at policy with a big P and with a small p, I think to Libby's point, is there something we want to do as a more unified voice in terms of advocacy with the payers right now? And then from more of a public policy and legislation standpoint, depending upon how this unfolds, there may be some action that we want to take in the broader, in sort of public policy arena to advocate for some action on a longer term basis, with policymakers, with legislators. And so I think that, The near term is this educational opportunity, but the longer term may be some data gathering and trying to unify our experience so that we can craft a unified advocacy agenda that perhaps could create some system change if that's in fact what we want to see.
Yeah, great, completely agree. Shelley?
Yeah, when we talk about educating patients about, we focus mostly today on pathways, but I just wonder if we're talking about transparency and what patients understand about how their care is delivered. It seems like we ought to broaden it to the other negative incentives out there that may affect the decisions about their care. When I talk to patients about buy and bill and the fact that their care is paid for on a chemotherapy margin, they're pretty horrified about that. So while pathways is another layer of that, it's not the whole picture. It seems like we ought to, if we're going to talk about transparency, it's not just pathways, it's bigger than that.
I agree. Yes, Lauren?
Linda, what about the issue of when you transition from being an active or acutely ill cancer patient to someone who's, chronically ill with cancer? And, if pathways get to a point where you say, oh, we're really cared about you having evidence-based care when you're, actively getting chemotherapy. But then what if that patient says, well, what does that mean no one cares about me when I'm getting the treatment for all those years after or before I relapse or something? So I just feel like we still haven't really grappled with that transition and how to really realize it's still a cancer patient.
Yeah. So are you talking about like long-term tamoxifen, for example, or are you
Exactly,
talking about
right.
watch monitoring
I was
or all of it?
I was actually thinking more of the patients who are chronically on medications, but then I transitioned to just people who are out there floating.
Yeah.
And so we're all talking about pathways as being a bad thing, but if you're able to change it and it's a good thing, do people who have chronic cancer feel like they've been left out? I don't know.
That's good. Okay, anything else before we wrap up? Now's the time. We've got the video camera here, so we can record it forever. Or not. Ted?
We shouldn't lose sight of what the Dr. Schumacher talked about, the opportunity with CMMI.
Yeah, great. Yeah, and I know that we owe you that framework. Ted, if you want to send me your information, we'll send it around in an email to everyone.
Absolutely.
Yeah, absolutely. We should inform that. Yeah, and that's informing a little bit of the work of the Center for American Progress. Seeks, they're sort of intertwined pretty carefully at this point in time. Okay. All right, great. So just to summarize a couple of things from today, I hear us continue to define the fact that we should keep patients at the center of care, patient-centered care. And I actually had somebody tweet me the other day that said, stop talking about patient-centered care, it should be patient-led care. Okay, all right, good pushback, thank you for that. So, I just challenge you to think about that, patient-led care. I know a number of us are often asked to be the patient voice. So just a quick reminder, we can't be the patient voice. We're not really patients unless we are one of those patients. So, just a challenge to be very thoughtful in how we gather the real patient voice and take that to the tables that we're speaking on. And a number of us are doing data gathering activities. So I know that any of us would be happy to share any of our data with you as you're moving forward into those conversations. I heard a lot about the importance of alignment and how do we really align what's being done around pathways or care models or quality standards and carry that to our work. So how can we deliver a common message? How can we reach people? And again, I love the example of the cancer insurance checklist because that sort of went out under whatever voice was launching it at the time. So it was the same press release, take out Kim's quote, add your CEO's name. And so that was a great opportunity to just really hit the marketplace with the same message through a number of different channels and voices. So thank you for that model, and I think it's something we should really think about moving forward. Transparency is key, which will also relate to the work that we are doing together. So just a little bit of follow-up. For those of you who attended the meeting on the 24th, you'll know that the videotape is on our website. The toolbox, I'm looking at Chris, should be going up in the next couple of days, I'm hoping, so that'll be available to you. Chris is also working on a toolkit from this particular meeting. The videos will be up in a couple of months. The slides will be up tomorrow. So if you want to take a look at the slides and reference Lawrence, we will get those up. We're committed to doing that tomorrow. We will collect names for those of you who want to join a coalition of how do we really start to help patients sort through all of this activity moving forward. And I will say to you, please stay tuned because we will be doing our next educational forum on the results of the Access Project. So that is the big study and the videotape, and hopefully we'll be having that ready for you sometime the end of January, early February. So to be determined. Okay. And with that, I'm going to thank you all again for being here with us. Kara, thank you, and Celgene for making this possible. And go enjoy your afternoon. Thank you so much.